I want to talk with you about work that we're doing to address a major cause of morbidity and mortality, which is this problem of suicide and suicide-related behavior. And I suspect that it is a tragic outcome that has touched many people in this audience, either directly or indirectly. It's become recognized increasingly as a major public health challenge. Each year in this country, 1.4 million people attempt suicide, and we've seen a 35% increase in deaths by suicide over the last 2 decades, even more shockingly, nearly 60% among young people, for whom it is now the second leading cause of death. And if you combine medical costs and work loss and quality of life loss, it's been estimated that suicide-related behavior accounts for more than $500 billion in economic costs annually. Now, healthcare settings are a crucial venue for addressing the problem, and that's in part because most people who attempt or die by suicide see a healthcare provider in the weeks leading up to the event, including nearly 75% in the 90 days prior to the incident. However, large-scale studies and reviews of the literature have shown that, first of all, only a minority of people who attempt or die by suicide have revealed their suicidality to healthcare providers. And a systematic review of 50 years of research has shown that clinicians do little better than chance at identifying who's at risk. In 2019, JCAHO, the Joint Commission that accredits healthcare organizations, required these organizations to screen for suicide risk for patients presenting with behavioral health concerns. And that's led organizations to use a small handful, typically, of self-report measures that ask about recent symptoms and suicide attempts, like the Columbia Suicide Severity Rating Scale. These are unfortunately only modestly helpful. So for example, in a large-scale study, the Columbia scale in ED settings had an AUC, which, where 0.5 is essentially a coin flip in terms of accuracy of 0.69 for suicide death in the following month, and the positive predictive value was 0.4%, meaning that 0.4% of people who screened positive actually went on to die in the next month. So we've been working to try to improve options for suicide prediction and prevention by leveraging the power of machine learning and artificial intelligence. And as you know, artificial intelligence is capable of making highly accurate predictions by mining very high-dimensional data. And we've been particularly interested in the vast resource of real-world health data that's captured in electronic health records, which represent a massive and continuously growing database of encounters with the healthcare system. In fact, at MGB, our EHR contains 3.5 billion rows of data. And these AI methods can incorporate, obviously, much more information than any individual clinician could, and they don't need to rely on self-report, which, as I indicated earlier, can be unreliable. So we began our work by developing and validating an accurate risk prediction model using machine learning and data from 1.7 million patients in our system. And the model performed quite well with an AUC of 0.77, which is considered quite good. It was able to detect 45% of all suicide attempts or deaths on average 2 to 3 years in advance. We then validated this approach in 5 other independent healthcare systems and found that it performed essentially just as well. We conducted a detailed economic analysis and showed that implementing our approach in primary care would be cost-effective when paired with evidence-based interventions. And so with that in hand, we began developing a clinical decision support tool with an eye towards user-centered design. So we conducted 10 focus groups with a diverse range of frontline clinicians to identify where are the pain points and how could we develop the most effective solution. We also tested our approach in a prospective study of more than 1,800 patients presenting to our psychiatric emergency services, and we derived and incorporated into our AI model a point-of-care brief survey measuring suicidality. We also asked the treating clinicians to estimate, what do you think is the likelihood that this patient is going to make a suicide attempt in the next month or 6 months? And after 6 months of follow-up, it was clear that our models were outperforming clinician performance. Once again, clinicians did not that much better than chance, as you can see from the AUCs there. For our model, the AUCs were 0.7 to 0.79, which is, again, quite good. But what was particularly striking was that among those patients that our model identified as high risk, 40% went on to make a suicide attempt in the next month, and nearly 60% within 6 months. And we think those are actionable numbers. To give you some context, these predicted risks are higher, actually, than many risk algorithms that are currently in use routinely in medicine. So, for example, statins are recommended for individuals whose 10-year calculated risk of having a cardiovascular event is 7.5% or higher, and the AUC for that widely used clinical risk prediction model tends to be in the area of 0.7. We've also recently completed a pilot implementation of providing these risk scores to clinicians in the emergency department. 86% of clinicians reported that the scores were clinically useful. So until now, there has been no EHR integrated clinical decision support tool that can incorporate evidence-based algorithms, multiple data streams, and stratify patients according to their risk and guide clinicians through the development of an individualized care plan. And that's actually what our tool does. So it is a web-based application fully integrated into the Epic EHR using the interoperable Smart on Fire API. It has a user-friendly interface that also provides contextual information that helps clinicians understand what the risk information means for their patient. It can incorporate multiple data streams, for example, the EHR risk profile along with the healthcare, or rather the point of care survey. It allows the clinician and patient to generate and document a safety plan and guides the clinician through the development of an individualized care plan. So we have now designed a randomized clinical trial to further test the effectiveness of this tool in a larger sample. We expect this to begin early next year. And we believe the market for this tool would be healthcare institutions, hospitals, perhaps payers. The Smart on Fire API essentially allows this to be integrated into any EHR. And we also think that it would reduce medical costs, which are estimated to be $235 million a year associated with suicide-related behavior through things like inpatient care, ED care and boarding, and so on. So we think that there is a strong financial argument in addition to the obvious clinical benefit that this could provide. We envision starting a new co or partnering with an industry partner to bring this app to production at scale and develop a licensable product. In the longer term, our goal is to develop a comprehensive platform that includes provider and patient-facing apps to support enterprise initiatives for suicide risk assessment and prevention. Our overall goal is to transform how we manage suicidality, which, unlike many areas of medicine, has seen far too little progress for far too long. And we believe that we can bend the curve on this tragic outcome for patients and families, and ultimately, we hope, save lives. So thank you for your attention.